We do like ports or biopsies, and they do everything as interventional radiologists. As a matter of fact, as you will know, vascular surgery is sort of dying, with all the respect I have for the surgeons, dying specialty because it's becoming everything endovascular now. So most of the procedures, they are doing some endovascular, and as you know, the FEMPOP has disappeared almost from the armamentarum. So in other words, the vascular surgeons, they are interventional radiologists for 6 months. Unfortunately, we interventional radiologists don't learn too much of vascular surgery, so we work together. As a matter of fact, that is the best thing for the vascular surgeon can do on their own without radiologists. But I don't think intervention can do without the vascular surgery.
Yeah, collaboration
so
is definitely going to be key. What do you have to say?
Yeah, hi, my name is Shaz Chachler. I'm from South Africa. Well, actually, I'm a Kiwi living in South Africa. I think that we're mixing things up here a little bit. The person who should be putting it in is what you've got the resource on hand. Now, where I work, I don't have a vascular surgeon. We do all our own vascular trauma surgery. We don't have an interventional radiologist. There's one for 5 million people. So if there's something that we can get somebody in, but that's only in working hours. So that takes the argument out of a lot of it. It's a person who's enthusiastic, who's got the skill set. In my setting, that's going to be the surgeon on site or the emergency physician on site. And like the panel here, I think the emergency physician can put a line in. Can they do a cut down? Yeah, it's a skill set you can learn.
Yep, we have a few questions.
Just a short comment on our institutional protocol. So as you asked about cut down, so most of our patients underwent REBOA through the cut down. And so our practice is we learn every trauma surgeon to perform REBOA. And as soon as the decision for REBOA is made, so the surgeon or assistant should call to vascular surgeon, and this vascular surgeon will solve this problem with this cut down.
Yeah.
And that is not a problem of a trauma surgeon anymore.
Yeah, it's a bit of a challenge for the skill set. Yes, sir.
Just a point. I mean, I don't think there's any reason for a cut down just to gain a femoral access. I mean, if you get trained well enough to do it and use the ultrasound, there's no reason to fail. I mean, if there's a reason to fail, it will be a reason not to advance your sheath or your wire, which is a different reason. That has nothing to do with gaining access.
Yeah, and I think we'll get better at it, but the data does suggest that people still need to do cut downs. Maybe that's a skill issue or not, but we had a question.
Just a comment on that. I think from the Scandinavian perspective, I think it's impossible to teach ER physicians to do cut downs. I think that would be skills of surgeons. But I think the focus should be on ultrasound-guided vascular access.
Yeah, I mean,
thank you.
We access femoral arteries without iliac occlusion or possible. So,
guys, what I tell you, when I sit here and listen to you, it's a déjà vu. It's a déjà vu for me because we had exactly the same discussion 20 years ago when it was about aortic aneurysm. At that time, 20 years ago, the radiologists, they had the skill sets with the catheters. On the other side, many of us vascular surgeons had the mindset, and we had this discussion. It's dead now. Don't do the mistakes we did. How did we got our skill set? We looked over the shoulders of the radiologist, and then we did it ourselves. So learn from our mistakes. Of course, if you have the mindset, all can get the skill set.
It's a great point and good comments. Thank you, sir. We have two more people on there who have not spoken on the panel, and I'm going to change frames here a little bit and give them a little bit of a different question. So let's say that Dr. Talving and Dr. Love, you both have trained and worked at some of the busiest trauma centers in the world. What would you feel comfortable with a provider at a smaller hospital who is appropriately trained, be that an IR provider or an ER provider, but they simply don't have the surgical capability on short notice, and they want to put a REBOA in and transfer that patient? That facility is about an hour away. What's your comfort level? What are the pitfalls? Is that a place where we'll get? And I'll start with Dr. Talving.
Thank you, Joe. You know, in the same context, the trauma system matures. You put it an hour away, and if that takes to save a life, I'm very comfortable to put it in, but I would kind of be keen to have a partial capability of that REBOA, because if you put it in for an hour, total occlusion, that most likely won't do. So only this as a silver bullet would not save the life, but a partial one to titrate the blood products and fluids and transport the patient to me to a big trauma center, I think that would be my advice anyhow. Put it in, titrate, have a partial capability, and a transfer.
Okay, Dr. Love, what do you think?
Yeah, I completely agree with that. Having said that, I think the only limitation to other individuals not being able to do a procedure would be my own ego. I think we can train just about anybody to do these procedures. That's not the question. It's doing it at the right time and at the right patient. And that's the question we have to wrap our minds around. So having said that, if a provider that has the skill set says to me, I'm going to put in a REBOA and send them to you, it's an hour out. That might be a little long, and we can debate the hour, the 20 minutes. Certainly 4 hours would be too long. And we're talking about transfers, and the reality is it probably will be 4 hours. Now, having said it on the flip side of that, if my concern is that the technique was done inappropriately, that's why I have a job. I'm there to fix the problem you created. So when we start talking about all of these different techniques, and I go back to what was said earlier about how we got ourselves in trouble with the vascular stuff, because you said this wasn't going to be the thing that we're going to. Everything's going to be open. Everything's going to be endovascular. If we stay with that same mindset, we're going to lose that battle. It's here. It's staying. This is a technique we're going to use. Whether it's our paramedics that do it in the military setting, which it's being done. We've already talked about it. You're going to present some stuff, I think, coming from Syria or somewhere that people are doing this. So again, the limitation would be my own personal ego saying that I'm the only person capable of doing this, and that's false.
So let's talk a little bit about different places where the balloon can be implemented, and jump to this issue about pre-hospital REBOA and transfer REBOA and ER or OR REBOA. So can we discuss even military aspects, because they are included in our session?
Yeah.
Maybe Joe, you would make a short comment about pre-hospital military REBOA. You published this fantastic paper of out of hospital REBOA. Please, could you comment, and then we proceed with panelists.
So we've got 7.5 minutes left, so let's find one from each side of the spectrum. Who in the panel believes that pre-hospital REBOA is something that could be done in the end of 2017, 6 months from now? Okay. Who believes that's a crazy idea? Who believes it's probably not a good idea?
Urban and civilian or military setting?
Well, we'll stick with civilian for the moment. So we have one person over here who thinks that's not reasonable. Why do you think that's not reasonable in another 6 months that we could be able to do pre-hospital REBOA in a mature trauma environment?
You know, you were asking before if a small center should put it and transfer the patient. I would say every center can probably put it. It has to have probably 3 rules. The one is to have people that are competent in putting it in, and I agree, I don't think it's a huge issue. ER, emergency, many different facilities can put it in. So this is the first thing, people that know how to do it, people that have a very good idea what they're doing with the patient once it's in, if he goes to surgery, if you transfer the patient and so on, and if the indications are very clear. So you need these 3 things. I think that a small hospital can put it in and to transfer a patient. I don't think that, as the audience here, and there's a lot of people here that agree that REBOA is needed, but among us, we don't really understand yet what are the indications for it. So if patients come to shock trauma center and there's 5 or 10 physicians over there and they're experienced in it, then they can discuss and say, okay, this is the okay patient. But if you're going to take a single physician out of the hospital in the ambulance or whatever and suggest to him in a chopper or an ambulance to put it in, and he's by his own, when we do not agree here yet what are the indications for it, which are the right patients, I don't think that we are there yet. Once we will agree what are the indications in the emergency room, who should put it in, and so on, and what are we going with the patient, so it will come. It's going to take I would guess more than a few months.
Dr.
Only
Manning,
by the end of 2018, not 17.
Maybe so. Dr. Manning, what do we need? You raised your hand saying you thought it could be feasible in 6 months. What do we need to get there? How do we get to that place?
Well, if you already have an infrastructure in place where you have, say, trained people in the field, physicians in the field, you're really at a point where you've got the infrastructure. You could actually begin tomorrow if you actually have that skill set. As I said, the London Area Ambulance System is already doing that. They've been doing this. SAMU doing ECMO in the field. And what I see, and this is an advantage that I think European, Australia, these countries have over, say, the United States, where we don't have those systems as infrastructure in the United States. That is going to be a real critical challenge for the United States, particularly in how do we actually take that level of skill, say, emergency physicians into the field. In the U.S., it'll be most likely emergency physicians. In Europe, it's sort of a mix of emergency physicians and critical care anesthetists. Is it possible? Yes. I think the big question is it comes down to making the right decision about an individual patient. If patients are dying in the field and you're at some distance from a medical care facility, their survival may be dependent on actually doing this. If you're 5 minutes from the hospital, even if they are a REBOA candidate, you may actually decide, no, we're going to transport this patient quickly and be in a medical facility with more assistance. So from a technical standpoint, I think that's less of an issue than making sure you do it in the right patient at the right time.
Yeah, and so much will be guided by how long we can leave the balloon up, hour versus 4 hour. Dr. Walgren, how long can the Zone 1 balloon stay up? And what do you use to make that assessment right now in 2017?
Yeah, I think that's a good question, and I think when you the shorter the better, of course, and you have a payback. We have had cases in our hospital where we have had the balloon in Zone 1 for 40 minutes with really severe bad ischemic reperfusion afterwards. It's difficult to say a time. You can do it partially, as we already discussed, which I think is good. You deflate the balloon and you open up a little bit, and you maybe have your sheath to secure the balloon in Zone 1. I think you can maybe rely on the clamp times, as you know we have had for vascular surgery. So I would say you should have a balloon less maybe than 20-30 minutes for the SMA and the celiac trunk. Longer. I think you're going to have some payback to do.
Yeah, Dr. Tom?
Joe, you and me, we've had many patients on the aortic cross clamp, and I can't remember any of those surviving more than 30 minutes. So what's the difference here? Well,
let me ask you, is it a fair comparison, ED thoracotomy and REBOA? I think that's what we naturally fall into as a community. And I think there is a gray area in the middle where the indications are very similar, and the skill set, depending on the skill set you have, you could utilize either. There are patients with pelvic hemorrhage I would not dream of doing ED thoracotomy on, but I would place a REBOA. And then there's the penetrating on the other end of the spectrum, the gunshot wound to the chest on a Friday night in Baltimore that I'm going to do an ED thoracotomy on. So that it's a fascinating question, and I don't think we necessarily have the answer at this point.
Yeah, I was commenting just on the ischemia, distal ischemia, by having aorta occluded, independent what's the mechanism of injury. Yeah. So, but whatever they are, like 30 minutes, I mean, they don't like to be, they're not coming.
Dr. Tolving and I worked at an institution where the only contraindication to ED thoracotomy was rigor mortis. If you could not get the arm up. So one more quick angle to this question. How many of you, when you utilize REBOA presently on the stage, utilize either total occlusion or nothing? How many of you utilize partial REBOA? So most of you are all up or nothing. Joe, you're saying you're all up or nothing. What about intermittent REBOA?
Yeah, intermittent
REBOA,
sure.
But still either all up or nothing.
It's all up or nothing, yeah.
So how many partial REBOA users on the stage? Okay, so we have a few.
Question for you.
Yes, sir.
I have a question for the moderator. Nobody mentioned here, but maybe we should, the use of the balloon in the IVC, inferior vena cava.
Yep.
And unfortunately, only we talk about arterial injuries, but I think caval injuries are even worse. They are killers more than the aortic. So I have only seen once in my place, but that's it. I don't have experience. Anybody?
Who's used the balloon occlusion for the IVC? Anybody in the audience?
So,
No? But certainly it's a skill set, right? So when we acquire this skill set, we can apply it in a variety of different, it is a tool, as Dr. Hoehn mentioned. It's a tool, and it's a tool in our toolbox that we can then utilize. What about zone 3 occlusions? So I think we all agree, everybody in the audience agree, it's probably longer tolerated zone 3. You don't have the ischemia to the viscera. What's the longest period of time? Anybody, what kind of times do people use on the audience? Just throwing out numbers. 30 minutes, 60 minutes, 2 hours? I think I've answered the question. We really don't know yet, right? So the data is still including. Dr. Lev, what do you use in your practice?
You know, I would say an hour certainly would be acceptable on zone 3.
I think we have some more talks on that this week, and we are...
Again, what you're comparing are two different things, right? So when you have an ischemic lower extremity, how long do you get before you make fasciotomies, right? And so I would, in my mind, equate those things a little bit closer together, much the same way as a thoracic cross clamp being 30 minutes with survivors, honestly. People live with ischemic legs all the time.
Well, Victor and I have been threatened if we go over, we will have our podium privileges revoked by Dr. Hoehn. Thank you all to the podium for an excellent session and some wonderful insights.
Thank you all for great talks. We will have now, thank you everybody. I just want to say some words. One, that we will have now a mingle, a bit food and drinks. So you're welcome to go to the exhibition area and mingle. Tomorrow night, it will be, on Friday, we'll have the banquet evening at the Elite Big Hotel. It's near the castle, and I hope you will enjoy yourself. I hope we will have good discussions and be active, because this is how we want it to be. Thank you.